Hello everybody, so we're going to talk today about DVT and pulmonary embolism. And the reason we're talking about these two together is because you can't take one and not talk about the other. About 50 to 70% of cases of deep venous thrombosis result in pulmonary embolism. So these two are intimately related. Pulmonary embolism is a significant cause of mortality, about 200,000 deaths per year. So what is deep venous thrombosis? All it is a clot in a deep vein. So as far as cases of deep venous thrombosis that get diagnosed, the ones that are clinically significant, they tend to happen in the lower extremity. Almost always, about 90% of the time, they are lower extremity thromboses. They tend to happen more in the thigh and the femoral vein more than in the calf and the popliteal circulation. But overall, it is lower extremity much more than upper extremities. What are the risk factors? There are 3 risk factors, and they are what comprise Virchow's triad, and that's venous stasis, injury to the vessel wall, and hypercoagulability. So let's start with venous stasis. What is that? Venous stasis is simply anything that causes the blood in the veins to move slower. And that can be bed rest, so you're not moving around as normal. Remember, the veins have a very low pressure. So in order for blood to move through the veins, you need to be getting up and moving around. So bed rest results in venous stasis. Obesity also results in venous stasis. Not just for the fact that people who are obese are usually sitting around, but because of the obesity itself, that's going to cause a slower venous circulation. And then just the fact of being post-operative, that is something that can that tends to result in venous stasis, mostly because these patients are already on bed rest. So venous stasis. Injury to the vessel wall is any kind of trauma that may happen to these veins. So that could be a surgery, that could be a gunshot wound, that could be a bone injury that ruptures that vein. That's not quite as common as the other two. And then hypercoagulability is just this laundry list of things. So oral contraceptives, that's quite common. Exogenous hormones, that's another thing that's common. You see that particularly in postmenopausal women who are taking exogenous estrogen to abate some of their symptoms, which could include hot flashes and vaginal dryness. And then inherited states like factor V Leiden, protein C and protein S deficiency, and antiphospholipid syndrome, which we would see, for instance, in lupus. And then, of course, pregnancy is a hypercoagulable state. You think of pregnancy definitely because there are some pregnant women who are on bed rest. So there you would have 2 major risk factors right there for DVT. And like I said, about 50 to 70% of cases of DVT result in pulmonary embolism. So what's pulmonary embolism? It's simply a clot lodged in the pulmonary arterial circulation. And now, depending on the size of the embolism, that's going to result in a various spectrum of severity. So if you have a large embolism, then that's going to block off more circulation than if you were to have a smaller embolism. So the severity of symptoms is going to vary. Some of them can result in sudden death, and some of them have very, very minor symptoms. Now, something we're not going to talk about, just as a side, but we're not going to talk about in this particular talk is what's known as a paradoxical embolism. And in a paradoxical embolism, what happens is you have a thrombus from the deep veins, which goes up into the heart, but it transfers from the right circulation to the left circulation through a patent foramino-valley. So if a patient has any kind of hole between the right and left heart, the embolus can move from the right heart to the left heart, and that can actually move into the brain circulation and cause a stroke. So that would be similar to what you would see if a patient had a like atrial fibrillation, where you're getting an embolus from the left heart up into the brain circulation. So that's not common, but it can happen from deep vein thrombosis if the patient has one of those heart defects. So pulmonary embolism, the symptoms for this are desaturation, which would result in shortness of breath, dyspnea, chest pain, and then an elevated AA gradient, which you would see on labs, and then right heart symptoms. And that's simply because, since you're blocking off the circulation to the lungs, you're going to have an increased pressure in your right atrium and right ventricles, and so that's going to transfer back pressure, and you're going to have an elevated jugular venous pressure and edema. So let's focus on deep venous thrombosis here. As I mentioned, the history, these tend to be immobilized, post-operative patients. Can also happen in if you're sitting for prolonged periods of time. So you think of air travel. If you're traveling from Chicago to Sydney, Australia, that's about a 15-hour flight. So that's something significant. Hypercoagulability, either inherited or acquired, as I mentioned, oral contraceptives, hormones, factor V Leiden, and then pregnancy. The symptoms of DVT include leg swelling and pain. That's the most common. Warmth and edema of the skin over the leg, particularly over the affected area, is also common. You can also see pitting edema and Hohmann's sign, which is calf pain on dorsiflexion. So that's a physical exam technique. You're forcing dorsiflexion of the foot, and that elicits calf pain. That's positive in approximately 10% of patients, but that's a very, very specific sign of DVT. For diagnosis of DVT, the best test is the duplex ultrasound, and that's done over the affected area. The problem with duplex ultrasound, though, is like any ultrasound, it's dependent on the person who is performing it. So if the person who's performing it is not experienced, you may have a misdiagnosis. Now, oftentimes DVT coincides with manifestation of pulmonary embolism, so it's very important in any patient with DVT to assess them for those cardiorespiratory signs. If they have any cardiorespiratory signs while they're having DVT, it's very important to get a helical CT, which is the test of choice in really diagnosing pulmonary embolism. We'll talk about that, specifically how to diagnose PE later on. The treatment for DVT, once it's been diagnosed, is low molecular weight heparin, which is, for example, Lovenox, enoxaparin. Of course, you can also give unfractionated heparin. That would be appropriate as well, but we tend to use the low molecular weight heparins. For pulmonary embolism, the history is going to be pretty much the same as with DVT, because DVT causes pulmonary embolism. Another thing that points towards pulmonary embolism is, of course, if the patient has a past medical history of pulmonary embolism, that also has been shown to correlate with an increased risk of PE. The symptoms of pulmonary embolism are going to include all the aforementioned signs of DVT. Approximately 70% of PE patients also have symptoms of DVT. They have that leg swelling, redness, etc. The cardiorespiratory signs are what we see in addition to DVT signs when we are thinking pulmonary embolism. So pleuritic chest pain, dyspnea, shortness of breath, heart rate greater than 100. And then some of the signs that we would see in a more severe pulmonary embolism would be jugular venous distension and hemoptysis. For diagnosis, there's really no one single definitive test. They all have a misdiagnosis rate. Generally, the best initial test is going to be a spiral CT. And it's kind of middle of the road. It's not the most accurate, but it's definitely more accurate than some of the other tests that may be ordered. So that tends to be your best initial test. However, some physicians will go with a chest x-ray first, but that's frequently normal in PE. So if you're going on the USMLE, I would go with a spiral CT as your best initial test. The most accurate test, however, is pulmonary angiography. That's your gold standard for PE. That's the most accurate test that we have. All possible pulmonary embolism patients should be getting anticoagulation, so low molecular weight heparin or just unfractionated heparin, while the testing is pending. So even before you send them off for a CT, you should be giving them anticoagulation even before you get your results back. So you're not going to wait to treat these patients. They should already be getting anticoagulation while the testing is pending. You don't want to delay this, because the longer they have this pulmonary embolism, the higher their mortality rate is going to go. So you need to treat their PE as quickly as you can. So if the spiral CT does indeed indicate pulmonary embolism, then the patient, of course, should be treated immediately. Generally, though, we're already treating them with the low molecular weight heparin or unfractionated heparin prior to the diagnosis. All of these patients with PE will need to be admitted, and of course supplemental oxygen is useful, but again, that's something that generally the nurse is going to have the patient already on. The cornerstone of therapy for pulmonary embolism is going to be IV heparin. These patients will be needed to be anticoagulated for a week. So IV heparin is administered, and after 2 days of heparin therapy, you can start them on their oral anticoagulation, which is generally going to be Coumadin, warfarin. And why do we start patients on heparin first before we put them on the oral anticoagulation? That's an important thing to know. And the answer is that we start heparin before warfarin because there is something called warfarin skin necrosis. So remember that warfarin blocks the vitamin K the vitamin K enzymes. So that includes various factors, but it also includes protein C and protein S. And because protein C and protein S have a shorter half-life, warfarin is actually going to block those first. So if you start a patient on warfarin without heparin, you actually increase their coagulability for a short period of time before you actually reduce their coagulability. So you don't want to start a patient cold turkey on warfarin before you have them on heparin. So you have the heparin started first, then you go ahead and start warfarin on day 3. You're going to be monitoring their INR. The therapeutic range for pulmonary embolism is between 2.5 and 3 units. You can stop the heparin after 7 days, but then you will continue to have them on oral anticoagulation for at least 6 months. So IV heparin first, or low molecular weight heparin, and then you can put them on the oral anticoagulation on day 3. If the patient has pulmonary embolism and they are hemodynamically unstable, which does happen in a minority of pulmonary embolism patients, if they've got the massive pulmonary embolism, you should be giving them a thrombolytic. So remember, your thrombolytic agents are TPA, tissue plasminogen activator, and then your recombinant TPAs, which include alteplase and reteplase. We do not do this for just general pulmonary embolisms. We only do this for pulmonary embolisms that are hemodynamically unstable. So if the question asks you about a patient who has 120/80 blood pressure, or even 130/90, and they've got a heart rate of 110, that's not a hemodynamically unstable patient. If it's a 90/50 and a heart rate of 160 or something like that, if the hemodynamics are not normal, then you go ahead and administer a thrombolytic, and then you will continue with the treatment as usual as you would for any other pulmonary embolism. So thrombolytics are only for hemodynamically unstable pulmonary embolisms. If you have a patient where anticoagulation is contraindicated, say particularly for a patient who has just gotten out of brain surgery, or any other patient that should not be on anticoagulants, then you should refer these patients to surgery. These patients will need a pulmonary embolectomy, which is an invasive procedure. You don't need to know exactly what it is, but basically it's where they go in like an angiogram and they bust up the clot. And then they'll need an IVC filter placed. And all that does is it filters out any continuing embolus that may come from that DVT. So if anticoagulation is contraindicated, these are patients that need surgical therapy, and that's pulmonary embolectomy and the placement of an IVC filter. So I like to use Wells clinical prediction for pulmonary embolism. There are various different clinical predictor techniques that you can use, or criteria, but this one's my favorite because it's only 6 different criteria, which are pretty easy to remember because they are your risk factors for PE. So basically what you're doing is you're assigning points to these different risk factors, and what this is going to be useful for is this dichotomous approach, which I'll teach you next. So if the patient has DVT symptoms, that's 3 points. So most patients who have PE do have DVT symptoms. So leg swelling, pain, erythema, Hohenstein, etc. That's going to be 3 points. If pulmonary embolism is number 1 on your differential, that's 3 points. If the patient has a heart rate greater than 100, that's 1.5 points. If the patient has been on bed rest, immobilized for more than 3 days, or if they've had surgery in the last 4 weeks, that's 1.5 points. If they have hemoptysis, or if they have cancer, both of those are 1 point. So with this dichotomous approach, a pulmonary embolism is likely if they total over 4 points. So basically, it's pretty easy to get to that 4-point level, because if they have DVT symptoms and an elevated heart rate, right there, they're at 4.5 points. And that's being in the likely range. And I should say that's greater than 4.0 points. And then pulmonary embolism would be unlikely if you're less than or at 4 points. Okay, so let's look at this so-called dichotomous approach. And it's dichotomous because you are either unlikely or you're likely. So if you're less than or equal to 4 points, you're considered unlikely for pulmonary embolism, and you're considered likely if you're greater than 4 points. Now, if you're thinking it may be a pulmonary embolism, but they happen to fall in the unlikely category, then your next step, rather than going ahead and doing a spiral CT, because you're thinking it may be PE, it's a possibility, but they fall into this unlikely category. What do we do? Well, then the answer is going to be to get a D-dimer. And what D-dimer does is it tests the level of a breakdown product of clots. So this is a very, very useful test. And it's a test that we do in patients that we're not sure that they have pulmonary embolism. And the D-dimer is useful because if the D-dimer comes back normal, you can rule out pulmonary embolism. If the D-dimer, however, is high, you can't rule it out. So if the patient's already kind of questionable for PE, they might not have it, getting that D-dimer is really useful because if it's normal, you can rule out, rest assured, pulmonary embolism. You can rule it out. If it's high, however, then you're going to need to continue investigating. And if they have a high D-dimer, then you're going to go ahead and get a helical CT. And you're going to get that helical CT just as you would if they were in the likely category. So if they already fell into the likely category by having more than 4 points, you're going to get the helical CT. So the helical CT is if they fall into the likely category or if they have a high D-dimer in the unlikely category. Now with the helical CT, you could have three results. You could have a high quality helical CT that shows that it's normal, and your radiologist will tell you if it's a high quality CT, and of course that depends. If the patient's moving around during the CT, you may get poor results. So this is only if it's a high quality normal result. If it's high quality and it's a normal result, you can consider alternative diagnoses. If you have indeterminate results from your helical CT, then you can go ahead and get a traditional pulmonary angiography, or you can get a VQ scan. And either of those will help you definitively rule out or definitively diagnose pulmonary embolism. If they do have positive findings of pulmonary embolism on the helical CT, then of course we're going to make the diagnosis and we'll treat them for pulmonary embolism. Okay, now if this is not necessarily information for the USMLE, this is real life information, so if you don't want to know any more information than you need to know for the USMLE, you can stop it now. But this is information that I like to impart to people because this is real life stuff. So this is information you can use on the wards, in the emergency room, with your patients, because you're going to be doing this in real life. This is not necessarily information, though, that you need to know for the USMLE. So it's important to know your lower extremity venous circulation anytime you're possibly dealing with a DVT case, because you are going to be getting an ultrasound of the DVT. Remember, what I said is that it is operator dependent. So you need to know how to do these tests in order to be able to make that ultrasound useful. So it's not just enough to know that you've got to get the ultrasound, you've got to know how to read it. So the places we're looking for DVTs are at the common femoral vein, so it starts right at about the ligament here, and then we go about 2 centimeters distal from the bifurcation at the saphenous vein. So, or I should say the feeding in of the saphenous vein, because we're going towards the heart. So you're going to start at your at the ligament and go 2 centimeters distal to the saphenous vein. So it's about this far here. Okay, and then with the popliteal vein, that's another place you're going to look. You should look right at the popliteal fossa. That's where your popliteal vein starts, and then you'll look maybe 1 or 2 centimeters distal to each of these trifurcation veins. So the posterior tibial vein, anterior tibial vein, and the perineal vein. So those are going to be the places, the major places you're going to look when you're looking for DVT. Those are most common places they come up. So it's useful to check both the femoral and popliteal vein, and what you do with the duplex ultrasound is you're going to look at the vein as applying gentle pressure, and then you're going to look at it applying direct pressure. So you're looking at it in non-compressed and compressed. And the theory behind that is that when you have a DVT, you are not going to be able to fully compress the vein. Veins are easily compressible because you don't have a high pressure in them. So if you have a normal vein, you should be able to compress it down all the way. If you have a DVT in that vein, you will not be able to fully compress it. So this is an example of a normal vein. This is a common femoral vein, and it looks like sort of right at where the saphenous vein comes in. And here it is with no pressure, and then here with direct pressure, and you can see that the vein is totally compressible. Now you compare that to here, this is the popliteal vein, so we're looking at a different place here. We're looking right behind the knee. And you can see here, the popliteal vein is this one right here. This is the popliteal artery. We cannot compress the popliteal vein. We're applying pressure, but we can't compress the popliteal vein. So this is an example where we have a DVT. Now you might not necessarily see the thrombus, and that's really not what's important. A positive finding for DVT is that you can't compress the vein. You don't really have to find the thrombus. And then here's another example. This is the common femoral artery, right at where the appears to be right at where we're looking at the vein here. This is the common femoral vein here, and so you can see this is probably the saphenous vein here, but you can see again we can't compress it. Even if you can compress it a little bit, that's still a positive finding. You should be able to get the vein almost completely compressed. So it should look something like this, where you've got it almost completely compressed.